Welcome to our daily roundup. We're going to be talking about button battery ingestions and what all surgeons should know. This work started as a task force with the AAP and has really extended out into APSA and other areas to really try to spread the education on what we can do as pediatric surgeons to decrease these injuries and also advocate with industry and the government to make button batteries safer. So Mina Wick and Joanne Berg will be giving the presentation today. Thank you all for coming, and thanks to the program committee for allowing us to present our work.
So many of us are very familiar with button batteries because they're found in many common household items like hearing aids, watches, car keys, and unfortunately inside our children too. So when ingested, button batteries can present with very non-specific symptoms that could easily be mistaken for something like an upper respiratory infection or the croup. So unless it's specifically been witnessed or highly suspected that a button battery has been ingested, the resultant delay in diagnosis can lead to very severe injuries because necrosis can happen in as little as 2 hours. Even once the button battery has been removed, the extent of the injury can continue to progress over the next days, weeks, and months. And unfortunately, this is a worsening problem. ED visit rates for button battery-related complaints has more than doubled in the past decade compared to the previous 2 decades. And in fact, nowadays, every 75 minutes, a child presents to the emergency room with a button battery-related complaint. So what can we as pediatric surgeons do to try and mitigate some of the injury caused by button batteries? Well, the first thing is to make the diagnosis quickly. Hopefully your emergency room knows, or if you're called with a child who has suspicious complaints like wheezing or cough or difficulty swallowing, to get an x-ray that includes both the chest and the neck above the clavicles. And for any trainees out there, make sure you use the zoom function to look at that foreign object and look for the characteristic ring sign or double halo that suggests that it could be a button battery. Once the diagnosis is made, the next thing that we can do is to neutralize the battery, both before and after it's removed. When a button battery becomes lodged or impacted in a tight space like the esophagus, the surrounding tissue connects the circuit between the negative, that skinny side, that narrow side, and the positive pole. That generates an external electrolytic current that hydrolyzes the fluid in the tissue around it. This generates a highly alkaline pH and the accumulation of a lot of hydroxide ions at the negative pole. And you can see exactly how alkaline that is by using a pH test strip. If the battery is free floating in the intestine or surrounded by a lot of fluid, there isn't necessarily the same injury that occurs because there isn't the same focal accumulation of those hydroxide ions. If you remember back to chemistry class, what do you do about a strong base? You neutralize it with a weak acid. There used to be concern that doing so would result in an exothermic reaction that would generate a lot of heat that might cause further tissue injury. However, this is proven not to be true. Both in vivo and in vitro models have shown that if you take a weak acid, like honey or carafate, and you apply it every 10 minutes to an ingested button battery, you can visibly and histologically see that there is less injury. That's why since 2018, the National Capital Poison Control Center guidelines have recommended before button battery removal administering honey or carafate to slow the rate of initial injury. Thankfully, these are both viscous, palatable liquids that kids will take and are fairly readily available either at home or in emergency rooms. The recommended guidelines are to administer it about 10 mils every 10 minutes until the battery is removed. This should not slow the rate at which you try to remove it and get to the OR. There are a few specific situations in which you should not give them. In cases of delayed diagnosis where it's been more than 12 hours since symptom onset, or if there's clinical suspicion of existing perforation, mediastinitis, or sepsis. The 12-hour rule is there because at less than 12 hours, studies have shown that the risk of perforation is much lower. If there's any known history of anaphylaxis to the honey or sucralfate, do not give it. And if the child is less than 12 months old, don't give the honey, but the carafate is safe. After the button battery is removed, you can still try to neutralize that acid to slow injury progression. So by administering 150 milliliters of 0.25% acetic acid, you can further decrease the risk of injury prevention. This is a sterile, commercially available product that can easily be stocked in operating rooms. Again, if there's clinical suspicion of esophageal perforation, including a fistula or mediastinitis or sepsis, don't give it. Practically, it can be administered fairly easily. So this is an example of button battery removal through a rigid scope. You can see that once it's removed, there's visible signs of injury. Here, the acetic acid is being administered through a separate plastic 4 or 5 French catheter, and then the excess is being suctioned out with that metal suction. This can also be done through a flexible endoscope or whatever scope you feel most comfortable using. And you can see that once it's all suctioned out, it visibly looks much better. The third thing that we can do, in addition to making the diagnosis quickly, and in addition to neutralizing that battery, is emergently remove any battery that is lodged in the esophagus. When you remove it, pay attention to where that negative narrow side is, because that's where the necrosis is most likely to happen. And knowing that direction can help you anticipate where any further injury might progress. Anticipate both acute and delayed potential complications. This may include doing an airway evaluation at the time of button battery removal, especially if that narrow negative side is facing anteriorly. You can also consider performing an esophagram, video swallow study, or a flexible laryngoscopy, depending on the degree of injury that you see at the time of removal. If the injury is really severe, you can also consider getting chest imaging afterwards to see how close that injury is to other major structures. That may help you determine where and how closely and how long to monitor that child. And remember, even once the button battery is removed, that injury can progress to fairly severe complications. So make sure to have a high threshold of suspicion of monitoring for them. To facilitate emergent removal, there are now 2 pediatric NICS-QUIT measures that are voluntary, but that you can measure at your hospital. The first is the time from the X-ray to the OR, and the second is the use of acetic acid irrigation. And for any centers that are interested in implementing such QI projects, APSA does have resources that are available. The first, if you scan that QR code, is a patient education sheet that you can give to families. And the second are toolkits that are available in the quality and safety toolkit related to this QI project.
Good morning. I'm going to talk about some of the advocacy efforts and injury reporting surrounding button batteries. The National Button Battery Task Force was established in 2012. It was established in response to the dramatic rise in the incidence of injuries between 2005 and 2010. The task force includes members of the AAP, the American Bronchoesophagological Association, and several other medical organizations. It represents a collaborative effort of relevant organizations from industry, medicine, public health, and government to develop and implement strategies that will reduce the incidence of button battery injuries in children. This slide illustrates all of the different stakeholders that the Button Battery Task Force interacts with. So it starts with educating parents on on button battery safety, medical professionals on best practices. Data is collected by poison control centers. This can be presented to the United States Consumer Product Safety Commission, and ultimately this can impact regulations and laws surrounding button battery safety. This slide is a table that just illustrates the multi-pronged approach that the Button Battery Task Force takes in order to make an impact on button battery safety. We work for regulatory standards, evidence-based protocols, and also interact with industry and try to motivate them to develop a safer technology. This slide is an important advocacy story. In 2020, Reese Hamsmith was an 18-year-old child that swallowed a button battery. There was a short delay in diagnosis, and she was hospitalized for over 6 weeks. Ultimately, she died from complications related to swallowing this button battery. Her mom decided that her death would not be in vain, and she started a nonprofit called Reese's Purpose. Reese's Purpose was able to garner over 80,000 signatures on change.org to advocate for better button battery safety. The petition led to Reese's mom testifying before the Consumer Product Safety Commission, and this led to a bill being written that was bipartisan and was able to pass through the House and the Congress in a relatively short time. President Biden signed Reese's law into law last August, and it mandates child-resistant enclosures on all lithium and non-lithium button battery containing products. So now, essentially, you have to be able to at least use a scissor in order to open a button battery. And also, warning labels are now mandated. Regarding injury reporting, I wanted to inform you about the Global Injury Research Collaborative. The GIRC is a nonprofit medical research organization that was started by our colleague, Dr. Chris Jatana. He is an ENT surgeon at Nationwide Children's, and he did this with several of his colleagues. Dr. Jatana has been very prolific in this space of button battery safety and has worked on all of those different aspects of from regulatory efforts to working with industry. The GIRC is committed to injury prevention through education, outreach, and research activities. Before the GIRC developed their injury reporting app, they did essentially a needs assessment, and they sent out an anonymous survey to over 400 providers that care for button battery injuries. They learned that probably less than 4% of injuries were actually being reported to poison control centers. But the providers indicate that they would report if it was more convenient. Dr. Jatana also reached out to industry to find out what data points would be needed in order to actually improve the technology so that button batteries would be safer. And in this GIRC app, these are highlighted the data points that are needed in order for industry to have information where they could actually make a safer technology. So it is a unique data reporting system compared to those that were previously available in North America and Northern Europe. And you can note that an object photograph can be uploaded into the app, and this is the first effort where we can actually also collect more outcomes data. At present, there are about 275 users of the GIRC app. You can upload it in less than 2 minutes. It's free of charge for medical professionals. It is designed for use by pediatric surgeons, ENT surgeons, gastroenterologists. The app is HIPAA compliant. It broadens our user base so we can collect more data. I've shown you some of the data points that it collects. And it's not cumbersome, it's easy to use, it's compatible with iOS and Android platforms. It takes only 2 minutes to advocate at the point of care for every foreign body injury case, and we need to report to prevent. And we're now happy to take your questions. Thank you.
We have time for one question.
Hi, it's Yusuf Gohari, Pediatric Surgery Fellow at the University of Nebraska. Would you consider implementing level 1 trauma when these patients present to the ED to expedite their presentation to the OR from the ED?
centers have, and some of those protocols are uploaded to the quality and safety toolkit just for that purpose. Because most hospitals who are reporting using that NISQIP pediatric guideline use a cutoff of about 30 to 60 minutes from time of diagnosis to getting to the OR. So having an institutional protocol either very similar to or utilizing a trauma, highest level trauma activation helps facilitate that.
Thank you very much to the presenters this morning on such a critical topic.